Welcome to the Linguistic Validation Café series, a place to gather, connect, learn, and grow together by creating community, embracing our cultures, and sharing our passion for linguistic validation. This is the space and time we take to embrace diversity and discuss how to improve the human aspects of medical translation. This is episode 7, Patient Voice Research Unlocked. Find out what qualitative research is and how medical translators and linguistic validators can play a role by transferring their cognitive debriefing expertise. With our special guests, Mark Gibson, patient voice research specialist, and Emmanuelle Jeannot, linguistic validation consultant, medical translator, and former human factors specialist. With our moderator, Rachael Lee. I am your host, Nur Ferrante, and this is the Linguistic Validation Café.
This episode is sponsored by GRC, putting the patient at the heart of research globally.
Well, welcome, and thank you so much for being here today, and to all those who have joined us for this open, relaxed, and informal and fascinating discussion. So today we're going to be talking about patient voice research with Mark Gibson and Emmanuelle Jeannot and Rachael Lee, who's going to moderate. Thank you so much, Mark and Emmanuelle, for accepting the invitation. And I'm going to invite you to introduce yourselves. Let us know a little bit about you and your experience. And maybe, Mark, you want to start?
I would have thought ladies went before gentlemen. Yes, I'm Mark Gibson. I have a company called Gibson Research Consultancy. So you can imagine that a lot of thought went into that company name. I'm the Gibson. We do research as consultancy, so award-winning company name. We specialize in patient voice research. A lot of people just know us as one thing. Like, for example, this community would just know us as linguistic validation, cognitive briefing, or whatever. Another group would know me just as health literacy. Another group still would know me just as comprehension testing, readability testing, information design. But at the center of all of that is patient voice. And that's really what we specialize in and really what we want to talk about forever, really.
Okay, thank you. Thank you very much. And also thank you for suggesting the idea, because Mark suggested the idea of explaining medical translators and linguistic validators, well, the possibility of entering or tapping into qualitative research or patient voice research. And this is a great opportunity for us. So thank you so much for your generous suggestion, because that will open professional ways for us that we maybe didn't think that were possible before. So really appreciate it. And Emmanuelle, tell us about you.
Okay, bonjour. So I'm Emmanuelle Jeannot. As you can hear from my accent, I am French. I am a medical translator, so working from English into French with something like 16 years experience. And the first thing I have to say in relation to the topic, I studied social psychology at university, and while I was studying social psychology, I was moderating qualitative interview, but in the area of consumer product. So might go back to this. So I did, some of you might remember me from the linguistic validation course. So I did the first session with Nur last year in June, which was very intensive and very interesting. From this, I went into linguistic validation and cognitive debriefing. And more recently, I went back, so I insist on the back, to moderating qualitative interview in the medical area, And so I'm going to be here to show you that it's possible, it exists. Somebody who went from cognitive debriefing, which I still do at the moment, to interview, to collect data, and to try to listen to the patient voice.
Wonderful, wonderful. Thank you. Thank you so much, Emmanuelle. Your experience is really unique, and it's going to be very, very valuable for all of us. And we have Rachael. Rachael, would you like to introduce yourself as well?
Sure, thank you. So I'm Rachael Lee. I've been a medical translator for just over 30 years. So I started out studying linguistics at university, and then I went straight into working for a translation company in Paris, which specialised in medical translation. So I trained in-house, and that's where I started doing work for the regulatory authorities, pharmaceutical companies, and then I went freelance. So I've basically been doing the same thing for about 30 years. And about 15 years ago, I started doing some linguistic validation work, basically back translation review for CROs, which I really enjoyed. And so last year when I discovered Nur's course, I took the plunge and I really enjoyed it. So I've been also doing some linguistic validation work for the past year as well, including cognitive debriefing. So it's allowed me to expand my skill set. So I've been doing concept elaboration, forward translation reconciliations, and clinician reviews, which I've really enjoyed doing. So patient voice research, this is a new area for me, so I'm really looking forward to learning more about it from both Mark and Emmanuelle.
Yeah, thank you.
So,
thank you, Rachael. Wonderful. I have a very fundamental question to ask, and that is because many members of our audience may not know what patient voice research is. So, Mark, I want to start with you and tell us what's patient voice research.
Yeah, I knew you were going to start with me. So patient voice research is essentially it's looking at the patient's lived experience of coping with a given condition, illness or disability or anything like that, and finding out about, from their point of view, through their eyes, what it is to live with X condition, let's say multiple sclerosis or diabetes or something like that. And within the pharmaceutical industry, this is often used to feed into drug development and the design of clinical trials. And I think my frustration is that I'm also a child of the 90s in terms of when I started my professional career. And I started with qualitative interviewing before I got into any other of the services like linguistic validation or anything like that. So I really got involved in it from an academic point of view. And I've seen it come and go. It's like a boomerang, it's in vogue sometimes and then it comes back in a different phase. And over the years, it's been called patient empowerment, patient insights, patient perspectives, patient centricity, and basically you just turn the word patient as a prefix or a kind of adjective, and then you attach a buzzword onto that, and now we've got patient voice. And so in many respects, I'm quite cynical about the sincerity behind the patient voice agenda with a lot of companies. If you go to any conference, you'll see any number of companies that we all work for actually just saying something or other, either about AI or about the patient voice. And in my experience working with a lot of them, they tend to differ in terms of their commitment, the real commitment. And that real commitment can be shown in subtle ways. For example, what their consent form looks like. If their consent form is 25 pages long and very complicated, that's not, they're not committed to the patient voice, even though they say they are. So I'm interested in looking at the assumptions behind that, and also just pulling the curtain away from the lack of sincerity in the area.
Mm-hmm. Okay, and what is it? What it's done in practice? I mean, could you like tell us in a nutshell? Because so like that we can make ourselves an idea of what happens with qualitative research or patient voice research. Because we know what we do in cognitive debriefing, but what it's done. I mean, it's the interviews. Can you explain just briefly, and maybe,
Yes.
I don't know, Emmanuelle, if you want to add something to what Mark may say.
So I think there are a number of ways to do a qualitative patient voice interview. And but one of the things I want to say is that, yes, cognitive debriefing can be a platform to be able to leapfrog to do qualitative interviewing, but it needs specific training. It really does, because an activity, I mean, I don't mean any disrespect. We're heavily involved in cognitive debriefing, but it is, in terms of research methods, the easiest research method that you could possibly dream up of doing. Other than standing outside of a supermarket with a clipboard and pen asking if you like this chocolate bar or that chocolate bar. Cognitive debriefing is on that level. I'm sorry to explain it in those terms. Like I say, I'm heavily involved in cognitive debriefing. Qualitative research is at a level higher than that, and it does need specific training. And there are a number of ways to do it. It could be structured with a very rigid, almost like a questionnaire, a survey based. It could be semi-structured, where you have a topic guide, and so you stick to certain themes that relate to the person's lived condition, and that is often informed by things like a literature review, scoping review, and then you just have a free conversation. And it's in those free conversations that the best patient voice insights are. But I also think that it's such a shame that methods such as cognitive debriefing and readability testing and health literacy testing are so rigid, and people stick to the script so clearly, so strictly, because these are also opportunities to explore the patient's voice, and very often they're not.
Mm-hmm. Very, very interesting. Very interesting.
If I can say so, if I can, so as I said in my little introduction, so I do cognitive debriefing, and I do as well qualitative interview with patients, so sometimes carers as well, sometimes parent of patients. That's another level. For me, the main difference is that cognitive debriefing, you're questioning the measure, you're questioning the clinical assessment measure and how this tool is understood by the patient or the person who's going to use them. It can be the carer. The difference, the major difference with, so me, I'm doing mainly in patient voice research. I mean, the real expert is Mark, but me, what I'm doing really is qualitative interview and moderating qualitative interview semi-directive, meaning that it's not completely open. I have a guide to follow. But the main difference is that in qualitative research for patient voice research, you're talking about the person. You're talking about the patient. You're not talking about the measure. It's much more personal. And you're talking about the person, about what topic? About his or her health. And most of the time, if he's a patient, is that because we are talking of ill health, of a sickness, a condition. So we are talking of something highly sensitive. And to me, that's really the difference with the cognitive debriefing. The cognitive debriefing is more, okay, look at this tool. Do you understand this? How would you say that? Can you rephrase that for me? It's a level of investment of the participant that is completely different. So I don't know if Mark.
No, I think you're right. But one of the things that I've seen a change, going back from comparing the MAPI. I mean, most of us who have been doing cognitive debriefing for a while, most of us got started with MAPI, and part of that was asking the question, how does this relate to your life? How does this relate to your life, and how is it relevant? And that's kind of been retired as a question, and it shouldn't have been, really, because it is relevant. And it's by looking at by that line of inquiry that you do get patient voice insights. And if you think about cognitive briefing, the amount of countries that it covers, where else are you going to get such an opportunity to do cross-cultural, multilingual, multi-country insights into patient voice research? But again, I suppose we're getting into, it's kind of a peripheral to the topic in question, but it is a point that should be raised.
I've got a question. So what kind of, expanding on a bit on what patient voice research is, what kind of companies are commissioning the work? Is it just drug companies, CROs or LSPs? And how do they actually use this data? I mean, what is the actual tangible benefit on patients' lives? That's something I'd really be interested in learning.
I think it's the most important question that could possibly be asked in patient voice research, and again, it scratches the difference. It scratches the surface of the difference between tokenism, just using patients just because you have to, so it can be a very superficial checkbox activity, or it could be something really in depth where it is meaningful and where the patients are actually brought in as co-creators and co-designers of a clinical trial. Now, that's what we want. That's what it should be. But in many respects, it's just so that, and but I would say the vast majority of patient voice research is that checkbox activity. As a joke, I wrote an article called the sliding scale of sincerity or something like that. And where are companies on that scale of sincerity, from 0 to 10, and most of them are on the under 5, let's say, on the scale of sincerity. And so what type of companies? Pharmaceutical companies, professional research companies, and there's lots of real dedicated professional research companies, CROs, and over the past few years, you have a lot of LSPs. Should I say jumping on the bandwagon?
So LSPs are doing patient voice research as well?
Yeah, well, what happens is that very often CROs commission this work, or pharmaceutical companies commission this work, and if there are, it's a bit like usability testing for eCOA or medical device or something, where procurement departments of pharmaceutical companies or CROs take the easy route. I mean, this is really controversial, and it's not going to win me any friends or business. It might lose me some. But so they say, well, this company already does linguistic validation and translation and cognitive debriefing and does all of the regulatory affairs and things like that. So let's give it to them. It's easy, that's a nice sell. So you would have an LSP that isn't just doing translation, but also regulatory affairs, labeling, linguistic validation, cognitive debriefing, usability testing, and of course, all of that is just outsourced wholesale. There's very, very rarely is there any in-house expertise amongst those companies, but amongst the professional research companies, there is the in-house expertise, and they don't tend to outsource unless it is in another language. Mm-hmm. And with the real opportunity with patient voice research is the fact that diversity is really important in clinical trials. And by diversity, I don't mean DEI type forced diversity, but real naturally occurring diversity. That necessitates patient voice research in as many countries and languages as, for example, cognitive debriefing is in.
Mm-hmm. And Emmanuelle, have you got anything to add?
No, not really. As I say, my experience is a bit at the other end of the chain, where Mark is a researcher and me, I'm just the little hand doing the interviewing. Mm-hmm. So I'm a bit. One thing, me and the people who give me work. So you were asking about the company who does that. So I've got marketing company who are doing marketing in the for the pharma industry. And I've got also something, and I actually translate a lot for this company, called field agencies. So field agencies are working sometimes for a market research, sometimes directly for the client, and who are specialized in organizing the field and in organizing, okay, we are going to have 60 interviews in Europe, 15 in France, and we are going to recruit the patient and recruit the people doing the moderators, doing the interview. So 1.1 advantage, because some of you who know me from Nur's training and our debate know that my bec noir in cognitive debriefing is the recruitment of patients. And I have to say that when you moderate qualitative interview, so far the recruitment is always done for me.
That's a relief.
Can I just add something to that? I think that's a really good point, and it both makes it easier for the outsourcee. So if I'm giving work to you, Emmanuelle, which I will actually.
Thank you.
So with recruitment, it tends to go through the ethical approval process in each country where that mechanism exists in that country. And so typically it's already handled by the sponsor. But we as a company get involved in that ethical approval. And for me, it's a much cleaner and a much more transparent way of doing patient recruitment. So I call that on radar patient recruitment. Whereas cognitive debriefing, it's very much a black box. You don't see what happens. And I call that under the radar recruitment, where it is, people just using any kind of, there's a number of strategies to get patients, and I think with the patient voice, the on radar way of getting patients. The work is already done, and I think that's better. I'd much prefer that for cognitive debriefing, but the problem is the timelines are so short, and the ethical approval process is so long. It just wouldn't be. It's not possible, really.
And so if we look at what the difference is between qualitative research, patient voice research, and RWE, if you could expand a bit on that for me, Mark, would you like to go first?
I think Emmanuelle should say what she said before, because it was beautifully put.
For me, so I don't know if it's beautifully put, but for me, qualitative interviewing, qualitative research is just one of the tools at the disposal of patient voice research. And on that, I will give the mic to Mark, who's a real specialist in patient voice research, and he might explain to us, what other tool there is.
Well, I think qualitative research, I've had conversations with Keith and also with Nur about the applicability of, or the advantages rather, of using one-to-one versus a focus group scenario. And I think that I've done tons of focus groups, and it's appropriate to some extent. But it is, if you want to find out somebody's individual story, yeah, it has to be one-to-one. It genuinely has to be one-to-one. If you're just looking for superficial views across the board, yeah, focus group's fine. Now, one of the things I find really funny, and it's in a snobbish way, to be honest, in an elitist way, is when I see companies in conferences where they talk about RWE and they use real world evidence and real world experience interchangeably. And it's the real world experience wing of this where we are looking, where it would be more appropriate for qualitative research, actually getting into the experience of the patient. Real world evidence is, based on clinical data often, and electronic health records and that kind of thing. And it's a litmus test or a shibboleth, really, where if you know that somebody's full of it or not.
Interesting. Yeah, because sometimes, we mix the terms. So we are talking patient voice research, RWE, qualitative research, and so on. Sometimes it's not clear, right? So I think clarifying this, it really makes sense. And I don't know if there's another term that you tend to use, and it's also referring to that, and it's the same thing, or more or less we got it covered.
Yeah, but I think it's what I said before. Over the years, it's manifested itself in several buzzwords, cliches, and it, who knows what the next one will be. But I remember just 10, 12 years ago, it was a really difficult thing to sell qualitative research. Because the preference was for quantitative survey-based stats and that kind of thing. The qualitative stuff was seen as woolly and not having that much substance, and then suddenly it becomes it garners regulatory support and mandates and things like that, and then suddenly everybody is doing qualitative research and acting as if they've always done it and always loved it.
I think one of the problems is a larger problem. So I did study social sciences, and so since I studied social sciences, and in a way after I went into human factors, and it a bit the same thing. you say social science, it is, you have large proportion of people, engineer, but also people working in the pharma industry, that consider it like something, you know, below. It's not really science, it's soft science. You know, there is a negative feeling about it. It's not, oh, it's not as good as here we have number and we can tell you it is the 30.5, you see? Here we are dealing with something that is the more hazy.
I have a question, sorry. In which scenarios are we using qualitative research? Meaning, is it within, we are in a clinical trial, so we are doing qualitative interviews to gather the experience of patients with that specific intervention or drug or something? Or is it, I mean, in which cases are we needing to do this? Or if you can give us some examples at least of the areas where it's required, the voice of the patient, the real experience, the real world experience, as you nicely said.
I think it happens all across the what would be the word, the spectrum of drug development. So it can happen right at the beginning where people want to know, you know, let's say we're talking about endometriosis. What is it that we want to know about what people want from a new treatment for endometriosis?
So what are the unmet needs, to use the term?
Unmet needs, exactly. I was struggling to think of that. Thank you. And then there are touch points all across the drug development phase where qualitative research is required. Like I mentioned in the just finding out about how what shape or form the clinical trial should take and where. It's part of the validation of clinical outcome assessments. I can't get out of the habit of saying clinical outcomes assessments. That's interesting because people have very recently started changing that and acted as if it's always been the case. It's like gaslighting. But I digress. And then it can be done, you know, just there are tons of areas where qualitative research is opening up as opportunities. And another one is during the submission phase, the marketing phase, where the medicine is out there and people are gathering data in terms of real world adverse effects. So pharmacovigilance is another area where qualitative research is required, and very often it can be combined. It's a very versatile method where it can be combined with any method of inquiry. So you could do cognitive debriefing plus qualitative research. You just combine it. It's almost like stickle bricks Lego, where you can just join it together on different things. It works with readability testing.
Yes, I think that was saying at the beginning, it is a tool. So you can use several tools in your toolbox. And actually, me, I would advise, yes, to use several tools because patient voice is not something. So I don't know, Mark, but it's not something easy, you know. And so, as many tools you got, you know, in your box, as you know, as I believe, better you can approach it.
Yeah, a place where we use both, right, is during questionnaire design, I guess. We do qualitative interviewing and cognitive debriefing.
Yes.
So could we, where do we fit cognitive debriefing really? I mean, it's like, would it be within patient voice research, but not the other way around? Or it's because in the end we are testing comprehension, but at the same time, it's the experience of the patient with that comprehension. So there is an element of the real world experience of that person with the illness, although it's in a translated instrument and so on, but they are providing. So do you consider that it's within patient voice research?
Yeah, that's absolutely all of it. Cognitive debriefing, health literacy testing, comprehension testing, usability testing. These are all just different ways of eliciting the patient voice. But my point before is that they're very structured and very limited in what they do. I mean, one thing for another debate is that I estimate that as far as a clinical outcome assessment is concerned, cognitive debriefing probably only tests about 40%, 35 to 40% of what could be tested in eCOA, and that is astonishing. And when you get to eCOA, it probably reduces to about 25%. And you know, we talk about tools, we talk about a box of tools, and adding some aspects of qualitative research can increase that scope of gaining further insights into a core.
Okay, we could inject into cognitive debriefing more aspects of qualitative interviewing, right? So we are not doing it because we are not aware that we can do it, and we are like shrinking the possibilities of cognitive debriefing.
Yes, yeah,
okay.
yeah, and it's like I wrote an article about knowledge management as applied to information design. So it's that. So there's known knowns and unknown known unknowns and that kind of thing. And this, what you said, is an unknown. We just don't know, or a lot of people don't know that they don't know that this is a problem. If you should do a Chomsky syntactic tree of they don't know that they don't know that they don't know. But but it is an issue.
Because it's true that in real experience, when you are doing cognitive debriefing, the very same patients are giving you their views on the questionnaire, even on questionnaire design or things that they realize that are not meaningful aspects of health for them, or things that are and are not represented there. So they are naturally adding that rest of percentage that you say that it's lacking. At least it's been my experience, but I can't do anything about it unless, I can just leave a comment or something, but it would enrich, it would improve a lot the questionnaire. And it's not, and when we have all the different languages, because it's from so many different cultures and perspectives, and even alphabets that may affect the way patients will answer the questions or even understand the questionnaire. So it's to me, it's sad that we cannot use all that energy from multicultural work and infuse it back into the questionnaire and reshape it accordingly as well. So
at the moment that would be classed as added value. And it's something that we would prize, but I can guarantee that when it gets to a project manager of a typical cognitive debriefing or linguistic validation company, delete, just gone. That nice to have.
I might have something. I'm going to be the devil advocate here, and Mark will not like me at all. But so the work I am doing, because we are talking here about medical translator going into or linguistic validation consultant, there is a big aspect. The big aspect is that, and that is typically central to a linguistic validation, we are working with different countries. We are working with different culture. We are working with different countries. And so it means that you are never the only person to do the research. The problem is that that is a frame, that is a restraint. Yes, a patient might tell you lots of very interesting things, but okay, you can note them, but you should not. You should always keep in mind, in my case, is the person in Spain, is the person in Italy going to go in the same direction? And my problem is, no, I've got a guide, and the company who, asked me to do this job wants to compare the data from France from Italy and from Spain.
Yes.
So we have to stay in the same direction, even if the patient wants to go this way, and that would be, yes, indeed interesting. If he goes that way in Spain and that way in Italy, the person, you know, the sponsor of the study, will not be able to use the data to compare.
Yeah,
You see what I mean? And that is also central to linguistic validation.
Yeah, but it's like really widening the scope and obviously applying it to all languages. I mean, everyone with the same criteria, let's say, because otherwise that would happen, right? But it's more in the case I was saying, it's more to inform even the source questionnaire, like to gather also all the multicultural information.
Yes.
And also
yes.
widen the scope of the patient's feedback and listen more. Like Mark said at the beginning, that at first MAPI was asking for a specific question and then they just stopped asking for that question.
Not MAPI, not MAPI in particular, but the industry in general.
Sorry, the industry.
Moved away from.
Yeah, they were asking for a wider scope from the patient, and that has been narrowed. So it's like maybe widening again its scope and so enriching.
That is something very interesting and a very good point, and that is something that I'm advocating for. I'm really advocating, and it's almost never done in my experience. So might contradict me.
It is.
So you've gone from being my devil's advocate to your own devil's advocate then.
Great. Something that is almost never done is a pilot interview, because a pilot interview would, like Nur say, allow you to expand and maybe to take, you know, interesting things. It can be different in every country, and then when you put them together, then you could have a tool to collect data, be it cognitive debriefing, interview guide, or questionnaire, that will take into account and then allow you to have a kind of unity between the country to be sure that you're measuring the same thing, because that is something central. And very often the client tells you, no, that's very interesting, but that's not what I'm measuring here. So I think this very interesting point you're making, no, should be made more often and at the very beginning. So Mark might have a different experience, but for me, it is almost never done. And I've got, you know, sometimes translating some questionnaire, and you're asking about the deadline and what it is. We're going to the field. The first interview is next Monday. You're not testing anything. You're not, no. So I don't know, Mark, what is your experience on that?
Oh God, how many days do you have? You know, weeks? In fact, is everybody sitting comfortably? Do you want to? I think there's a whole different topic, to be honest, that we could get into.
There's the whole cross-cultural differences as well, and I was wondering, you know, if this is something that can be used for concept elicitation, if you could sort of really combine it and get more patient, if the patient interviews at the concept elicitation stage, would that be something that's really valid? You know, could be used across the different countries in creating the instrument really with the patient's voice? You know?
Absolutely. I think everybody is realizing, particularly from the experience of COVID, that like I said before, naturally occurring diversity is really, really important from the outset. And so developers need to be thinking beyond their immediate culture, and you've got to be thinking, right, rather than just designing for this to be used in a couple of clinics in Illinois or Wisconsin, we've got to maybe be thinking about Paraguay and China and Samoa, you know, just 3 extreme examples, or not so extreme actually. You know, we've got to be thinking designing for the world right from the outset. And at that point, that's where there is an unmet need, where we need to be assisting developers and pharmaceutical companies and CROs to do that. And what better input than having linguistic expertise right at the forefront of that? And again, that is just, it's hardly done, it's if at all, but it will be.
Mm-hmm.
I think it'll be a growth area, so that's a good point.
Yeah, that gives us a whole episode, and a second episode with this topic, which we will do, tackling diversity, because I think it's paramount for us. And I don't know, Rachel, if we can move on to asking them about how linguistic validators can dive into this. What's Emmanuelle's experience as well, and maybe for the group to start joining and asking questions, and let's see how this can be done in practice for us.
I think that's a really interesting question for translators, how we can transfer our skills. Is it something we can sidestep into? And have you got any practical advice for medical translators that would like to expand their skill set?
So it is, I mean, it is possible. I have an example, I've done it. So going from medical translation to linguistic validation to qualitative research. So when I say that, it's limited to the moderation of interview. But me, what I would like to highlight really are the differences. So touch on it a little bit before, is that a cognitive debriefing, the way I have been tasked to do them, are very guided, you've got a COA with 10 items. How does the patient understand? Can you rephrase it? You know, it's really very, a qualitative interview to me needs another level of skills and quality, because we are talking not about the tool, we are talking about the person, we are talking about the experience of the person. It's deeply personal, and it is most of the time we are dealing with pharma, and we're talking about patient voice. So by definition, if you're a patient, is that there is something wrong with you? And that is another level of being deeply personal. It's one thing to say, okay, this question, if you're in your COA, me, I would say it like that. And something completely different as to answer, okay, this side effect has this impact on my quality of life. Mm-hmm. And you have deeply personal things coming out of that. Mm-hmm. And to me, the difficulty of doing an interview is that you have to have a level of empathy and try, to have the patient talking and not having any barrier, any problem, opening up about a deeply personal topic while staying on course. Because as I said before, at the end of the day, and it's very cold to say that, but we are collecting data, and data that needs to be compared in Spain, in France, in Italy. Mm-hmm. And that's all, for me, that's all the things that you have to be empathetic, but stay on course. Quite often you have a time, you've got 1 hour, it's quite a classic time. You go through an interview guide that is very often very long. You need to know it, by heart, because it might happen that the patient suddenly in the conversation, in the discussion, is going to jump to another topic. and you need to guide the patient and to stay on course and on topic without looking too cold. We still, you know, saying, yes, I'm interested in what you're saying, and without being frustrating and you know, negating in a way, gaslighting and saying, okay, let's go to this topic, might be understood that, okay, what you say here, I'm not interesting at all. I'm not interested in that. Yes, you are, but that's not what you're collecting. And that is all the balance, all the thing that the gymnastic a little bit that you have to do when you're moderating an interview that you don't have when you're doing a cognitive debriefing or the cognitive debriefing I have done.
Mm-hmm. And do you do these interviews in person, or you do them online, or how is the framework?
I do them online.
Mm-hmm.
I do them online for one simple practical reason. I'm interviewing French people and I'm based in the UK.
Mm-hmm.
Something important as well that we mentioned when we chatted in the discussion room before this webinar is that for me it is very important not only to be a native speaker of the same language as the patient, but to me it is important as well to be from the same country, meaning that a French person, I mean, they speak French in Belgium, they speak French in Canada, they speak French in Switzerland. You don't have all the culture, all the reference, all the, you know, the little word that the patient will say that is in reference to, you know, a cultural fact happening in France or something that is, you know, very known. And that also because the main thing is, I mean, to stay natural and to stay.
And I'm thinking about now as you're speaking, the patient burden and also maybe the compassion fatigue that the interviewer can have. And to me, those are two issues that maybe, Mark, I don't know if you have any insights on that within the framework of patient voice research.
I think, yeah, it's not something that can be taken lightly. For me, it sounds really corny, but the way I see it is it's as important as you know, like cultures that have oral history passed down from person to person. And you know, this is a story of one. This is an oral history of one, and you're responsible for that. You're holding it. It's like carrying fire. You know, really, it's just it's really precious, and it's, you know, this work. The responsibility goes all along the chain of command, I suppose, from the sponsor to the company that is being commissioned the work. That company needs to have that same level of empathy, which doesn't happen, and the interviewers need to have it as well. And sometimes you can get into a situation that absolutely knock you sideways, and you can be carrying some trauma. The interviewer can be carrying trauma. There's been times when I remember like a handful of interviews where afterwards I've cried. You know, obviously not in front of them, but it's just been so traumatic. The story, their lived experience is so traumatic that they stay with you for weeks and weeks, and that's why I'm saying it's precious.
As I said, we are not talking about a product. We are not talking about an item in a questionnaire. We are talking about life.
Yeah,
and that can be. And I know something. Some company tells you, okay, when are you available? And can you do one half an hour after? I seriously cannot, even in the best of case, even if I'm not completely. So I had recently interviewed, the study was on parents. So that's another level, the parent of pediatric patient in a clinical trial. And that, I mean, you can feel all the emotion, you know, of something sometimes very, very tough happening to the child of the. I cannot do another interview half an hour after. I need at least 2 hours break. You know, if possible, walking in nature, because the problem is that even if I was not completely tired, there is a risk of carrying that trauma. Mark used the term of trauma, of carrying it into the next interview, and you have to be extremely careful about that.
So you have to build skills like, of course, resilience, and also because from what I see, it's like when a patient is talking to a doctor, normally, well, they tell their symptoms, but everything goes very quickly, and sometimes our medicine is not as humane as we would like to. But in these interviews, we are like focusing on all that patient is feeling and many aspects. And for the duration of that interview, it's like that person is absolutely naked in front of us with all the vulnerability. And maybe it's the first time in his life or her life that is expressing it in that even orderly manner and comprehensive way. And the person is listening to herself, but also it's very intense, and that's at the same time, I think it's a beautiful, I guess, experience, and also therapeutic, although it's not thought maybe in the first place like that. But at the same time, it requires from all of us many skills, a lot of balance, and to be able to cope with that. It's like when you are a healthcare practitioner of in any field, you get very exhausted with treating patients, but sometimes you don't treat them like an entire hour, listening to what it really matters to them and all their story, right? And you receive all of that and you guide all of that. And I think that's very intense.
The thing that is very difficult is that you have to have this empathy, you have to have, you know, the patient to open, but at the same time, you have to be cold. You have to keep in mind that you're collecting data. You have to keep in mind that you have, very often, you have a script to follow. Yes, it's open, but you have to keep in mind that you have a time to keep. So it requires sensitivity, but at the same time, a cold head and time management skills, you know, something that looks very cold in front of some participants. So I'm talking back to the parents here, who are, you know, opening and telling you things that are sometimes really overwhelming. But I've got 13 questions next to ask, and I've got 45 minutes left. That's this balance that to me I found really exhausting.
I think
go ahead.
No, but I think building on that, I think there are other skills that are really difficult to teach, and you know, but if a person does cognitive debriefing properly, one of those skills is already acquired, and that is probing, being able to probe further for information. And as we know from cognitive debriefing, some people do it better than others, and others fail miserably at it. And so it's a difficult skill to get, but also active listening. You know, just listening to what the patient's telling you. But I think there's a lot of unsaid, unrecognized skills that are transferable from translators anyway. And it's got nothing to do with interviewing. It's about analysis of the data and synthesis. And that is a role where it could be a very fertile role for a translator to get into, helping with the data analysis. Obviously, you need training for it, but you have a natural predisposition to that purely because of the nature of the skills that you acquire during translation. It's just a matter of developing peripheral vision and seeing, right, this skill set that I'm using here is equally applicable to there. And that is one. Data analysis and synthesis is one of those examples.
You're talking about training. Oh, sorry. Yeah. So how can linguistic validators or medical translators with experience in cognitive debriefing can learn how to do qualitative interviewing?
Well, there is there's tons of just behind me are about 3 dozen textbooks about qualitative interviewing. It's not a great secret. It's there. Mm-hmm. It's out in the public domain. But like I said before, you know, the translator who has experience with cognitive debriefing should not get cocky on the basis of doing 2 or 3 cognitive debriefing projects a year. You know, it takes you somewhere to deal with qualitative interviewing, but not all the way. Maybe a third of the way, and the other 2/3 requires training and experience. I have a transcript that a client has allowed me to use. It was a client that used a translator with cognitive debriefing experience to conduct a qualitative interview with a cystic fibrosis patient. And if I may, I would like to read just 4 lines from it.
Sure.
So this was done in a European country by a European translator. I'm not giving more details to that.
It's not me.
No, it's not. It's not. It might be from a German-speaking country, maybe, you know. Okay. So the interviewer says, already starts really shaky and nervous. And I know the audio off by heart, and I could hear the rustling of the topic guide, and you could hear the scribbling of a pencil, I think. So the interviewer says, hello. So we talk about your disease, cystic fibrosis, yes? Can you say how you feel about it? And the patient says, now the patient is already receptive to the interview because she was recruited by her doctor, her treating doctor. And so she really wants to take part in this. So on the basis of that god-awful start from the interviewer, the patient says, hello, yes, it's something I've lived with all my life. Some days are better than others, but mostly it's exhausting. The treatments take a lot of time. The interviewer says, yes, treatment, writes it down. What is it like? The patient says, it's hours every day, inhalations, physiotherapy, pills. Sometimes it feels like it's my whole life. It's lonely as well. Interviewer, yes, lonely. So next question, do you work? And it's like that all the way through. And so the client originally came to me to, can you fix this kind of thing? This was about 12 years ago when this happened.
I have to say that me in the qualitative interview, I am asked to perform. Most of the time, I've got a quite precise discussion guide. That is just a guide. Yes, you have to adapt according to the patient, but you're not. I have the feeling that the moderator you're talking about is a bit, left alone and doesn't have precise guide to follow.
No, they had a topic guide because it was the same topic guide that I had to use when I helped them fix the project with other interviewers. And also from the audio, I could hear the rustling. The interviewer was fumbling with something, so it was obviously a printout of it. So that's the peril of just thinking, yes, I've done this, now I can do that. No, you need training for it. And one of the things that I forgot to mention is that the translator who wants to get into interviewing is competing with hundreds of thousands, literally hundreds of thousands of professional interviewers out there. You know, so there's that. And the only reason, to be completely frank, why a translator would get that work is because they cost less than the professional interviewer. I mean, that is the naked truth, really.
I was going to ask what added value a translator could offer in you know, as a qualitative interviewer then. So
a translator with cognitive debriefing and a medical background, let's say, or at least some medical training, or at least because it's true that well, many of the linguistic validators here don't have a medical degree or psychological degree, but are passionate about medicine and are studying and have many courses, and even, you know, they just read every day, even more than someone who has an official degree. So taking into consideration that it's, let's say, the elite of a cognitive debriefer that is medical translator, right? Let's say that it's a person with all those skills, right? So what would be, I would add that to Rachel's question. No? It's not the regular medical translator who doesn't really care, let's say, for more knowledge.
But I think we, I mean, in English we say we're preaching to the converted anyway. The people who are listening to this now are already in that elite sector. There's no question about it. And you know, I've seen the inner workings of your course and all that you do, and I was absolutely blown away by the depth that you go into, and the intricacy and the granularity of it. It's an incredible course, and anybody armed with that is going to be a really excellent addition to the linguistic validation world. I sincerely mean that, and you're not even paying me to say that either.
No, you are, because you are sponsoring us, by the way. So
yeah. Well, I
thank you so much again, by the way.
No,
the sponsorship
I sponsor
of this
because it
Linguistic
means
Validation Café.
It's an expression of how much value I put on this group. You know.
So what are we adding as linguists and
me, there is something
question,
else,
please.
if I can interrupt the flow of congratulations, which actually I completely agree. And having done myself the training, I think that all the people who do the training are exceptional. No, seriously, we're talking about the skills to go, so from translation, then linguistic validation, and then jump into the qualitative interview. I think that also there is a back effect, and doing qualitative interview inform your work as a translator. And I would actually recommend, but I mean, that isn't something that it's probably just a dream at the moment. But I would say translators translating the guide, working on all the COA tools and things like that, but also not just the translators, also the designer, the original designer of all these tools. I think they would greatly benefit from doing one, if only one, interview with a real patient, because that's a problem of training as well. Some company might offer you training, but it is one of the project manager, and one of the project manager is answering the question like that. A patient is not. A patient is going to tell you about his life, about, and I think all those people working, along the chain, going backward, would greatly benefit. And in a way, it should be in their training from doing one interview with one real patient.
I've found even doing linguistic validation, cognitive debriefing, looking at these instruments, it's definitely had an impact on my own translation work, translatability assessment. I think they're all really valid tools that can really enhance your work. You know, it's almost as if, you know, I look at my work with a new set of eyes. It's been really enriching. So.
I would like to ask the rest of the group if you have anything to ask, because you have added some comments, but I see that at the same time they have been answered one way or another. So would you like to say something, ask something? Any of you?
I just want to, can you hear me?
Yes, is it Keith? Oh,
yeah.
Yes, Keith. Keith Meadows, go ahead. Yes.
Relevant to everything that's been spoken about here in the last hour and a half. Today, Nur and Thomas Lepp and myself, we submitted a paper to a journal on to put forward recommendations for conducting cognitive debriefing. And today I got the editorial feedback in that both reviewers thought I've sent the email but on to Thomas and but both reviewers felt that the paper was good. It was adding something in terms of providing guidance in conducting cognitive debriefing, and based on that, if we address the revisions that have been asked for, then the paper will go through. But one of the interesting things that one of the reviewers brought up was, and what Mark has just been discussing in some length, is training. And the reviewers pointed out that this is something that is very rarely ever discussed. And we were congratulated, the reviewer has congratulated us on bringing that in, including that in the list of recommendations. So, that transcript that you read out, Mark, I mean, gosh, it's toe cringe, it's toe curling, that, you know, how can someone be so pathetically poor in conducting an interview? And you were saying, you know, well, you might do 3 interviews, but that doesn't give you the right to go ahead and think you're great at doing cognitive debriefing. And this is something that really does have to be what am I looking for? This is something that really has to be stressed, that it's not just something that someone can pick up. Oh, I'm just going to go and do some cognitive debriefing, or I've done qualitative research. Qualitative research, as we've been saying, is a basket of tools. And because you might be able to undertake an in-depth interview with someone doesn't mean to say that you're any good at doing cognitive debriefing, and vice versa. And so there's a lot of emphasis that I feel needs to be put into this training element around cognitive debriefing. And as Rachel has said, you know, understanding a little bit more about cognitive debriefing has actually helped her in her work as a translator. So, and this goes back again to what my opening gambit about, you know, we need to do a little bit more on questionnaire design. If you know more about how questionnaires are designed and to look for weaknesses in questionnaire design, then that's going to help you do your cognitive debriefing and cross-cultural adaptation. So it's a pretty complex bag of issues, and I honestly think that in all the literature, this has not really been totally exploited and discussed. And in papers they talk about cognitive debriefing, but no one ever talks about, when they talk about cognitive debriefing, what do they mean, and what approaches are they are they using? There's a call for far more clarity. And I think Mark's transcription really does illustrate that we've still got, although it was 12 years ago, I'm sure it's still often the case now with unskilled interviewers carrying out just that kind of approach.
I think there is really a big, to use a term very often used in the pharma industry, I think there is an unmet need for training. And to be honest, I was so pleased when I found no training on linguistic validation, because honestly, there is not much else.
No.
And on top of it, and we're talking about mainly medical translator moving to this, you have the problem also of being a translator. And I'm in the UK, I'm based in the UK. And the problem is that in the UK, being a translator is not regulated. So you can have somebody, who speaks two languages and thinks he's a medical, he can be a medical translator, or just a translator, forget the medical. And sometimes you have some results that are scary, because I do a lot, so I translate, but I do a lot of revision. There is one other problem. I mean, I think Mark and I, we can talk 3 days non-stop. There is one of the problem is the problem of time, and the time that is dedicated and the time allowed for translation is shrinking.
Yep.
And I'm sorry, I'm not doing, vite et bien, as we say in French, fast and well. It really goes together. So I'm doing a lot of revision. So I'm looking at the work of a fellow translator, and I can tell you that some of them, it's absolutely appalling. So it is as shocking as your example of an interviewer. And I think there is really an unmet need, a lack of training. So thank goodness for Nur and the training in linguistic validation, because there is really a giant gap here.
Yeah. Well, at least the reviewers, they were generally positive in their feedback, which Nur and Thomas Love will be able to see for themselves. Obviously, with quite a lot of revisions to the paper, but they felt that the paper is filling a bit of a void where there is no real clarification on how to approach these things. And it's I mean, there is no such thing as the cognitive interview in which we can describe, because there's so many variations on undertaking a cognitive interview that you can only recommend what approaches or to outline the different approaches, and then for the reviewer or the interviewer or the organization to decide on best practice that suits their project. But yeah, but as you were saying earlier on, Emmanuelle, that you get a questionnaire, and then they're telling you that they're going to go into they're putting it into the field next week. It's just it's balmy. The people are these people are educated, they're trained, they're qualified, they got degrees and everything, and they're still working like this. We'll give it to the translator today, but we're field testing it in 3 or 4 days' time. It's ridiculous.
Thank you. Thank you so much, Keith, for all your insights. Really, yes. I think we have someone else that raised the hand. Is it Cathal? Yeah, Cathal,
yes,
go ahead.
Indeed. So, Emmanuelle, you just mentioned about timings, and that was something that came to mind. So I've conducted a lot of cognitive debriefing interviews over the years. And it seems to me from the various clients that I work with, timings is something that is front of mind for them. So the time that we have from when we're assigned the files to conduct the interviews, I'm wondering, for qualitative research, how do you manage, and I guess this is a question for Mark, how do you manage those timeline and those expectations with clients? Because if, you know, if those interviews with respondents are more detailed and there's more information being gathered and there's more analysis of each of those interviews required, I would imagine that that will affect on timelines, and that would involve setting expectations with clients. And, you know, so I guess it's a two-part question. How do you manage those expectations, and are companies open to those, let's say, extra timelines to manage the qualitative research?
I think there's two things. So on the one hand, there is the ideal, what I live by, and then the other hand is just the client spec expectations, and the pulls apart. And of course, qualitative research projects are still following the same kind of hamster wheel as cognitive debriefing. You know, just throughput. And of course, I always, and you know, it's just getting worse and worse. I envisage it as like a vice, you know. So on one jaw is time, the other jaw is price, and in the middle is a balloon called a project, and it's been squeezed, and it's just something's gonna give. But you know, we're living in a time where, in a context where not every company has the same philosophy. Like I said at the beginning about patient voice research, and patient voice research, to be done properly, it needs time. The data needs to be collected, it needs to be analyzed, it needs to be distilled, and people need to make sense of it, and that takes time. And then so you have two types of products. You have the deep product, which is what I've just explained, where it takes time. And then you have the service level product, which is otherwise known as quick and dirty. And to be honest, the vast majority of research is that. Qualitative research is just the quick and dirty stuff. And, you know, I have to succumb to it because I've got kids to feed, you know, as much as anybody else. But it's those pressures of time, price, and the balloon in the middle.
Thank you so much
Thank you
for your questions. And Mark, could you recommend, because I know you have a blog and you publish many articles which are really insightful, would you recommend the group some readings maybe there that if they are interested they could start with?
Yeah, I think the knowledge center or the blog space, we got a website developed from scratch, so it's not like a, what do you call it, a Squarespace or anything like that, or a WordPress or something. This is actually a website that was developed from scratch. I'm supposed to be an expert in usability testing, and I'm embarrassed about my website because, you know, it's not usable. So immediately on the back foot with that. So, but if you have a look on grc-health.com, and then on the knowledge center, I think there's 100 and odd articles. I try to write about 10 a week. Just stuff that's bubbling over and I've just got to get out. But there's a lot of articles about patient voice and patient engagement. And I talk about the assumptions that very few people even acknowledge about that is necessary for patient voice to happen. And that is shared decision-making and patient empowerment, or in the opposite order, patient empowerment and then shared decision-making. And in reality, very few people are empowered. But that goes back to social sciences, the ability to deconstruct, and that is terrifying for. Without sounding like an anarchist or anything like that, it's terrifying for the powers that be. In fact, I mean, the Trump election was won as a reaction against that deconstruction that a knowledge of social sciences brings. And so social sciences and insights of that can really deconstruct, not just deconstruct, but absolutely demolish the slogans around patient voice, the insincere, empty slogans around that. And that's what I write about. I should have, I think that, and I'm going to be turning all of those into explainer videos, but that takes ages to do that, and I've got a business to run. But I try to do that.
And talking about explaining videos, you have a project of training, right? And
yes.
Could you share that with us?
Well, let's be honest. This is your course.
Well,
we are
yes.
co-designing it under Art of Diversity, and we're going to be focusing on patient voice research, qualitative, the deconstruction, because it's really important to understand the building blocks of the patient voice agenda, and how-tos in terms of qualitative interviewing, and what we want to do is have like basic, intermediate, and advanced courses, and I think those will really equip you to take on qualitative research, because it is a very fertile and actually very satisfying area. Once you get involved in the patient story and then the analysis of that, it blows your mind, really. And it makes activities like cognitive debriefing just really humdrum, in comparison, and I really like Emmanuelle's description at the beginning of getting back. And I was exactly the same. I started off in this type of patient story research, and I feel that I'm back as well, but I call it back to the Garden of Eden. Having a sojourn in comprehension testing and linguistic validation and that kind of thing.
That's wonderful. Thank you. Thank you so much, Mark. And Emmanuelle, would you like to say something to our colleagues? Any further recommendations to dive into, or just like a final note, let's say?
I mean, I don't know if I would dare. I'm just here to be an example. No, me, what I would like to highlight, and the last point, because we might have been a bit negative according to what the state of the industry at the moment. But the thing is that, yes, it is extremely rewarding. It can be very rewarding, and as I mentioned earlier, it will inform all your other activity as a medical translator and as a linguistic validation consultant.
Wonderful. Thank you. And lastly, Rachael, you that, well, it was relatively new to you.
Yes, it's been really interesting. Thank you so much to Mark, Emmanuelle, and Nur. I feel that I've learned a lot from you. It's been super interesting. And it does seem, it seems like a deeply personal kind of work. And, it feels like it's something that would be a real privilege to do, to be allowed, to be able to listen to patients, to have that opportunity to hear their experience and hopefully put it to good use. It seems, really, it does seem like it would be really rewarding. So thank you so much for all of, all your insights. And
thank you. And I will leave it to you, Mark, to close this and tell us a positive thing that may encourage us also to dive into qualitative, patient voice research.
It's just the depth. We talk about the sublime. It really is just something that you can just really be immersed in it, and also just the reading around the qualitative patient voice research in particular.
Mm-hmm.
And let's not forget that one of the things I should have mentioned is it's not just pharma where this is appropriate. You can get into health promotion, you can get into community engagement, you can get into the research that comes before the creation of health messaging, for public health and global health and consumer health research and that kind of thing. It's really, and also if you talk about erosion of service propositions by AI, patient voice research is going to be pretty much protected for now. I hope. but no, really, I think it is. We've got to think about that as well. And I really think that the linguist, the translator, has the best possible mindset for this. Really, I started off as a translator very early in my career, and very early I left it to get into this.
Yes, I can understand. Yeah, and in the end, it's a way of being very, very close to patients and really have an impact, which is a beautiful part of our profession, right? To contribute to the improvement of patients' lives. That's what it's in the end, the marrow of it. It's patients. So
the marrow.
Yeah. Well, it's been amazing. Thank you so much to both of you and to Rachael for moderating, and to all of you here today with all your insights and presence. And well, I hope people who are watching us may get inspired and maybe give it an opportunity to patient voice research. Thank you so much for this episode, and see you in the next.
Thank you for having me.
Yeah.
Thank you.
Thank you. Thank
Thanks
you.
for having me on.
Wonderful. And see you in the next Linguistic Validation Café.
Thanks.
Thank you so much for joining us today, and especially to our community of the Linguistic Validation Café, since this is a joint venture and its creation is the result of all of us together. The Linguistic Validation Café is an informal monthly gathering within the Art of Diversity Linguistic Validation Training Program.